Hello everyone and welcome back to our podcast. It's been a while. We know it's been a while. So I'm Fran. I'm one of the infection control nurses.
Hi everyone, I'm Jen. I'm one of the senior infection control nurses.
So as I said, it's been since October of 2024 and as we all know, it's been a little bit busy.
Yes, we've had a pretty hectic winter period. So apologies for the hiatus, but we are back and we will aim to come back to bringing, monthly podcasts again as per usual.
Yeah, exactly. So for today, we have two very special guests with us today who are going to talk to us a bit about a project that they've been doing. So I'll let you guys introduce yourself and take it away.
Yeah, hi. So my name is Matt. I'm a F1 junior doctor who I'm now in my second rotation, but I started in the respiratory department and I'm currently working with the mental health liaison team at Gloucester Royal Hospital.
Hi, my name's Suraya. I am also an F1 at Gloucester Hospital. I'm currently on acute medicine, but I also started in the respiratory department with Matt.
Cool. So thanks for coming, guys. What project have you been working on?
So we started on the respiratory department, bit of a trial by fire. It's a very busy department. People are very sick, have a lot of chest infections, are on a lot of antibiotics. And we kind of would go about our ward round and notice that a lot of the patients had been on IV antibiotics for, days and days, no review. And we wondered if we could maybe do anything about that. So that was kind of the impetus for our audit that we did during that first rotation. So I don't know if, Matt, you want to talk about kind of what the aims were?
Yeah, so just to add a bit, anecdotally, I think going around on ward rounds and stuff, you often feel like you don't properly do a review of all the medications and the antibiotics and people often stay on longer. So there was sort of this idea of can we maybe improve that because we know that staying on IV antibiotics has consequences. Which we can maybe go into a little bit more detail later.
Yeah, that would be helpful.
We just wanted to look at sort of what is the current situation, how well do we review antibiotics by just going through sort of ward round entries, how often is it actually mentioned, and then to maybe reflect on that data, share it with the department and see if we could actually improve any of the practice by sharing that.
Yeah, that's amazing.
Yeah, so what's the kind of background, what are the aims of your project?
Yeah, so obviously antibiotics are quite a hot topic at the moment with fighting antimicrobial resistance and antimicrobial stewardship and that sort of thing. And we know that IV antibiotics, although they're very good in very acute and severely unwell patients, do also have negative consequences. They have more complications and side effects in patients. They mean patient needs cannulas and that sort of thing, which obviously has an infection risk. Yeah. Needs more staffing in terms of nursing and that sort of thing. Putting up IV antibiotics is more labour intensive. The side effect profile is worse when they're delivered IV, and a few of our references, go into the sort of thing as good randomised controlled trials that show switching early to orals has similar clinical outcomes in terms of the period in hospital, but lower complications and less side effects. And of course, there's the big thing of cost. Yeah. Oral antibiotics are much cheaper, both in terms of the actual antibiotics themselves, but also in terms of the staffing required.
And all the other equipment required. Yeah.
Well, and then there's the whole environmental thing, obviously, that IVs, you require a lot more plastic materials and single-use things that with something like IV-Tazocin, for example, where patients are getting 4 doses in a day sometimes versus 4 tablets in a day, that's quite a dramatic difference.
Yeah.
Well, I think we've collected a bag once of the amount of plastic waste and just stuff that generates, and it's a lot.
It's
so
a huge amount, over like a course of. I think we did it over a course of Tazocin, and it was absolutely enormous. Like the waste impact is huge.
Yeah,
and obviously, there's just the patient experience. I think having cannulas in and out, and they keep tissuing, and you need new ones, and you see people just with loads of cannula sites and stuff, and no one's sure which one's flushing anymore. And I think it's just it tidies things up a bit if you really think about do they need them or not, and can we take the cannula out and move to orals? I think that's nicer for the patients ultimately.
Absolutely.
It's kind of like a streamlining kind of effect of all of that all coming into one together, which is really good.
Yeah, and like Matt said, there are all these negative consequences and side effects of using IV antibiotics, but we have really, really robust evidence over many years that early switching to orals has the same outcomes for the patients and also reduces hospital stay length. So so it's really in our interests. So that kind of leads us onto our audit. So the standard we used for our audit is basically a national guideline. It's also a trust guideline. And so NICE guidelines say that IV antibiotic therapy should be reviewed at 48 hours from initiation and then also daily thereafter. So all we wanted to find out was on our department, for people with pneumonia who are being treated with IV antibiotics, how frequently was this review being done, as it should be done 100% of the time. So in terms of data, we kind of limited our scope, like I said, to people who had a diagnosis of community-acquired pneumonia, who were treated with IV antibiotics on the respiratory ward. And then we just went through the ward round entries for these patients to determine whether or not a clear review of antibiotic therapy was documented or not. And so in terms of our findings for that first round of data collection, I don't think our department was doing too badly, but it turned out that patients were getting, I think, a review about 70% of the time, which is not too bad. But we were trying to see if we could do any better than that. So we had a teaching intervention, which was supported by the antimicrobial pharmacists and I think the antimicrobial lead for the trust, who were really helpful in all of this. And we just held a small teaching session for the juniors in our department. And re-audited afterwards. And we found that we were able to improve appropriate reviews by about 20%. So about 90% of patients were getting 48-hour reviews of their IV antibiotics. So that was really encouraging.
Was that just with the one intervention of a teaching program?
Yes, it was. Yeah, so we just did the one initial teaching. It was mainly to junior doctors on the ward.
Yeah.
But as Rhea mentioned, we had a consultant microbiologist there, Dr. Rob Jackson, and one of the pharmacists, Elitha Hin. And we just sort of presented what we'd found until then and sort of our rationale behind what we've just chatted about, why it's important to switch. And did a little PowerPoint, and things seemed to have an impact, which is really great.
That's amazing.
That's really great.
That's such a huge impact for patients. Over a relatively small intervention, really.
And we've sort of also discussed it with the consultants, and they were quite enthusiastic. So we were then invited back to the ward for the next rotation of doctors, because obviously we're all in rotational trainings. So we've been able to present to them now the same sort of
to hopefully keep it going without you guys actually being there. That's very exciting. Well done, you guys.
Do you have any plans to sort of take it further than our trust, or is it just trying to cover everyone we've got for now and make it our own?
So we were quite lucky to be able to present at the National Foundation Doctors Presentation Day. So that was really exciting. We both went. And we're hoping to present next rotation as well, do the same teaching again in the next rotation, and we're hopefully going to re-audit as well, just to see how that process can be replicated. And in theory, I guess, kind of have that 10-minute teaching session maybe for every rotation of of juniors in the department, and maybe go to other departments as well. So that's where we're at the moment.
Okay.
And obviously we focused sort of on teaching to the respiratory department, but we have, through Dr. Rob Jackson, who's the microbiologist, he's invited us to join him for one of his antimicrobial stewardship grand rounds.
Brilliant.
So next month we'll be joining. So in a way that's scaling it up to the whole trust a little bit. And we have registered to present at the National Patient Safety Conference in Bristol. We haven't heard back yet. But that sort of hopes that we can have a bit more of a national impact maybe as well.
Yeah, that's amazing.
Yeah, especially being junior doctors as well. Like, it's really great that you're, I mean, we're not doctors ourselves, but really great that it's at such a junior level, taking on such a responsibility, because it's such an important subject. So, just going back to it, what did you find were some of like the more difficult parts of coming up with how you're going to do it? Any kind of drawbacks, anything like that at all?
I mean, we had a lot of support, which was really great. I think, drawing support from people who are more experienced than you is always really helpful. So we reached out to, like Matt was saying, some senior people in kind of the antimicrobial stewardship team. I wanted to shout out Alice Liu as well, who actually collected the data for us initially, and then we were able to analyze it, which was so helpful and saved us a lot of time. So I think, working as a team with, widen your scope to not just doctors in your immediate vicinity, like doctors in other departments, or the multidisciplinary team is really, really valuable.
Yeah, absolutely.
And I think in the end, when we were first sort of brainstorming what we'd like to do, it's very easy to be quite idealistic and sort of think we're going to reform IV antibiotics completely in the respiratory department. But actually, we narrowed it quite a lot in terms of what we actually looked at, and it created quite simple criteria, which made it seem, on the one hand, maybe a little bit sort of simpler, but much more easy to actually tackle and have realistic data collection and actually have some outcomes that you could really measure.
And make it more sort of replicable for ongoing use, so that you're not making it a difficult thing to maintain. You want to make it as easy as possible, don't you? Because then it's going to continue going forward, which is amazing.
Yeah, really good. So what were some of the results of your study?
So, like we said, the main finding was we had a good increase in the rate of appropriate 48-hour reviews of the IV antibiotic therapy, so from about 70% to about 90%. But we also looked at a few other data points. So we were looking at people who had appropriate daily reviews after the 48-hour review, which stayed about the same. Although we were quite harsh in the grading criteria. If they missed a single one, we said it was a failure. So take that as you will. Other things we mentioned were average course length of IV and oral antibiotics. Interestingly, that didn't actually change between the two audit periods. We're not really sure the reason for that. It could be that we audited first in the summer and then in the winter when people are more unwell or have more things going on. But that's, something to note. And then the other thing that we kept note of was the percent of patients who didn't have an oral step down. So somebody who stayed on IV antibiotics for the entirety of their course and then was just taken off antibiotics at the end of it without a step down. And that reduced quite significantly, and we're not sure if that was us or not.
We like to think it was.
Is that sometimes appropriate that actually patients do require that entire course of intravenous antibiotics and they may not be appropriate for a step down?
So certainly in some infections, I think one thing to note in our study was that we only studied people with pneumonia, where in general that isn't appropriate. But, if we're thinking about the NICE guidelines, they do kind of exclude deep-seated infections from that 48-hour review because, of course, those patients need a prolonged course of IV antibiotics.
And, on the respiratory department, for example, you get patients with bronchiectasis who'll come in just for a 2-week course of IV antibiotics. But they wouldn't be coded as a pneumonia. Of course, there is the possibility that some of our patients were coded as a community-acquired pneumonia, and later it was established they actually had something else, and the way we analysed the data wouldn't have picked that up. So we might have, there's always going to be a bit of uncertainty in the data in that sense. But it is quite a marked decrease in the number of patients who went from having no step down to having a step down.
Yeah, that's really interesting. Yeah, I guess there'll always be some slight variables in the data that you have no control over, things like coding and stuff like that, and further diagnoses. But it still speaks for itself, doesn't it, results-wise, which is amazing.
And we'll hopefully on Antimicrobial Awareness Week in November.
You'll be our guest of honour.
Yeah, we've got some lovely blue wigs, so we'll get the blue wigs out and do some rounds and stuff.
Everyone can dress up as a bacteria.
Yeah, exactly. We'll do that as well. Thank you so much. It's been really helpful.
Yeah, thank you
really
for
great.
coming on and sharing this project, because it's really amazing work and it should be absolutely celebrated.
Yeah, definitely.
Yeah, I really wish you luck with the conference in Bristol. I hope you get that.
Thanks.
But I'm sure obviously you guys tell me different, but if I'm sure if anyone has any questions, then you can be contacted.
Oh yeah, gosh, please.
Absolutely.
I'm Suraya Foster. My email is suraya.foster3@nhs.net. I would love to receive any emails. If anybody wants to, replicate this project in a different department, I think that would be really exciting. Like, please reach out. And I'm sure Matt would also be happy to be contacted.
Yeah, absolutely. So I'm Matthew.Mirkin, Mirkin @nhs.net. More than happy to sort of share what we've learnt and get involved if people want us to.
Amazing, thank you. Yeah, and if you guys are happy, we'll just pop your emails on the sort of front screen of the podcast so that they're viewable as well, which would be brilliant. But yeah, thanks again for joining us. And
it's very nice to meet you both. And
nice to meet you guys.
Yeah, hopefully we'll be back with another podcast sooner rather than later. As I'm sure people have noticed, we're going through a little bit of a norovirus spell at the moment, so we'll be back as quickly as we can entering the spring months, which should be nice. So as usual, if you need to contact us, we're on extension 6122 for Gloucester and 3129 for Cheltenham, and we always contact on our emails as well. But yeah, it was nice to chat to you all again, and
nice
we'll
to be
speak
back.
to you soon.
Thanks everyone. Bye.